Hello, good morning, good afternoon, good evening, everyone. I'm Ann Ballard-Sarah with the USAID funded Knowledge Success Project. Thank you all, thank you all so much for joining our webinar titled Integrating the COVID-19 Vaccine into Primary Healthcare, Lessons from the Experience in South Africa. This is the second webinar in a series on integration of COVID-19 vaccine hosted by the Knowledge Success Project. So before we begin, please note that French interpretation is available for this webinar, and we're asking that all participants please select your preferred language, whether that's English or French. You can do that by clicking on the little globe icon at the bottom of your screen. And because we are providing live interpretation into French, we are asking all of our speakers to speak a bit slower than they may normally, and we'll be pausing before we switch to each next slide to give our interpreters a chance to catch up. I would now like to introduce our moderator for today's session. We are pleased to be with Dr. Hina Brambach. She is the Global Health Security Team Lead at the USAID South African Mission. So Hina, over to you.
Welcome, everyone, and thank you for joining us. I'm Dr. Hina Brambach, the Global Health Security Team Lead at USAID's South African Bilateral Health Mission, and I'll be the moderator for today's event. As Anne mentioned, this is the second in a series of 3 webinars on COVID integration into primary healthcare. Today's session will take a deep dive into examples of integration in a service delivery, health information and electronic data management in South Africa, and the role of the National Department of Health in supporting COVID integration. Our third session will be held in September, and we will be soliciting input from all of you to help determine the topic for that final webinar in the series. Before we get started, I wanted to take a moment to introduce the incredible and highly experienced panel of speakers with us here today. Christina Yarrow is the Deputy Director of the USAID COVID Response Team. Next is Marion Schonfeld, who serves as the Pharmaceutical Policy Specialist for the Expanded Program on Immunization at the National Department of Health in South Africa. Wendy Ovens serves as the Managing Director for Right to Care Health Services in South Africa. And finally, Melanie Walmarans is the Chief Director of the National Health Insurance Information Systems at the South African National Department of Health. Next slide, please. Today, we will start with an introduction to USAID's COVID integration guidance from Christina Yarrow. I'll provide a brief overview, basically setting the scene for the presentations that are going to come on South Africa's COVID integration program. Marion Schonfeld will then provide an overview and context for South Africa's integration plan. Wendy Ovens will cover the integration of vaccination into routine health services, giving the example of one of the provinces in South Africa, the Eastern Cape. And Melanie Walmarans will speak on the scale-up and implementation of the National Electronic Vaccination Data System platform and the development of a data integration ecosystem. Lastly, Knowledge Success will provide a few closing remarks. Throughout the session, please write your questions for the speakers in the chat. We'll pause to answer them throughout. And with that, I'd like to invite our first speaker, Christina Yarrow, to begin her presentation. Over to you, Christina. Thank you.
Thanks so much, Hina, and many, many thanks to all of our Knowledge Success partners for all their work in getting these learning opportunities off the ground. We're grateful for the participation of South Africa Mission colleagues, the South Africa National Department of Health, and outstanding local partner Right to Care. I wanted to take a moment to set the stage for our conversation today and share with you USAID's perspective on COVID-19 integration. I'll touch on principles, definitions, landing on today's topic pertaining to information systems and the innovations born here in South Africa with its Electronic Vaccination Data System, EVDS. Next slide. It goes without saying that as the COVID-19 pandemic has evolved, so too has our response. The end of the PHC, as we call it, in May marked the end to the acute phase of the COVID-19 pandemic, and also solidified the need for new tools and approaches to respond to this phase of the evolving pandemic. This new phase requires moving from mass campaigns for COVID-19 vaccination which really served an important purpose, as we all know, in rapidly reaching target populations, to a sustainable approach where COVID-19 prevention and response measures are integrated into primary healthcare structures. Now we are focused on integrating COVID response into country health systems, and particularly primary healthcare, so all countries are prepared to prevent and detect COVID and respond with treatment and care for those infected as part of their routine health services. The WHO UNICEF guidance that you heard about last week in the webinar brings us a common definition of integration and core principles to guide these efforts. And at USAID, we have adopted this definition with a small change to reflect COVID programming beyond vaccination to include testing and treatment. So we are seeing it as the partial or full adoption of COVID-19 response activities across prevention, diagnosis, care, and treatment into national program services, including immunization programs, primary healthcare, PHC as we say, and any other relevant health services, with the overall aim of improving program efficiency and sustainability, enhancing demand and improving user satisfaction, achieving and maintaining satisfactory coverage, and addressing inequities. We also remain fully aligned with the core principles of equity, people-centered, context-specific, and optimized service coverage. Despite the universal agreement on the need to integrate COVID-19 response into primary healthcare, operationalizing this integration remains a challenge. Policymakers and health workers need guidance on how to implement changes at different levels of the health system to achieve the desired integration. Last week's webinar highlighted some of the COVID integration tools and approaches that country-level stakeholders can use to answer this question of how to integrate. So, as shared last week, a companion resource to the WHO UNICEF integration guidance is USAID's compendium of illustrative sub-activities for integrating COVID-19 response into primary healthcare, which can support policy and program managers in initiating, building on the integration process and developing a country-level COVID-19 vaccination integration plan. The compendium provides a systematic outline of illustrative sub-activities organized, as you can see, around the WHO Health System Building Blocks framework, similar to the UNICEF and WHO resources. This week's webinar, we will want to shine a spotlight on the critical building block of health information systems that you see here in red outline, and share the example of South Africa's EVDS. So as with most public health emergencies, consistent and reliable information is essential in efforts to stop the spread of COVID-19. Across the globe, health information systems and digital health technologies are being leveraged to support communication and information sharing, disease monitoring and surveillance, and the delivery of healthcare services, including the COVID-19 vaccine. Throughout the pandemic, USAID and its partners have invested in the data and data systems needed to capture COVID-19 vaccination data, track coverage gaps in real time, reduce data backlogs, and assist governments in making data-based decisions. In some instances, the pace of the pandemic required leveraging new or standalone dashboards and tools. And as we continue to move towards integration, maintaining a data-based focus on COVID will help us to continue to reach high priority populations. And this will only be possible if data are integrated into existing systems to ensure relevance and ease of use. USAID is very interested in supporting data and health information systems to continue to build on the advances in health data made during the information-rich COVID pandemic. Many of these investments were made through USAID's global digital health and health information systems mechanisms, including DataFi, CHISU, Digital Square, and others. I wanted to share just a few country examples so that we can collectively get warmed up, so to speak, for the main presentation today. So in Côte d'Ivoire, Global Vax support was leveraged to integrate COVID-19 data collection and reporting into the national DHIS2 system. This allowed for timely use of data to inform decision-making and orient COVID-19 programming at the national, regional, and district levels. In Tanzania, USAID equipped regional and community health management teams across 5 regions with the technical skills to use the Chanjo COVID app, a digital tool used to track COVID-19 vaccination data. USAID also supported the development of an offline version of the app for use in areas with unreliable internet connection. In Honduras, USAID supported the implementation of situation rooms, as they were called, which brought together a cross-sectoral leadership team for structured and sustained data review and coordination to bolster the country's COVID-19 response. This practice resulted in improved leadership capacity for using data to plan and make evidence-based decisions. The situation room approach is already being adapted in Honduras to address other health areas, including TB, influenza, Mpox, and maternal mortality. And then in Eswatini, the Ministry of Health, with support from Global Vax, developed and launched ESWAVAX, a national electronic COVID-19 vaccine registry and data collection system that captures not only COVID-19 vaccination data, but also data about vaccine supply, cold chain systems, and adverse effects following immunization, or AEFI, as we say. Eswatini is now working to integrate ESWAVAX into the country's client management information system, a PEPFAR-supported health information system used in more than 70% of health facilities across the country. So to close, I really believe these examples set the stage for our deep dive into South Africa's EVDS, a phenomenal example of a digital platform and complex management system that allowed South Africa to plan for and implement its national COVID-19 vaccine rollout, and that paves the way for innovations ahead. And with that, Hina, back over to you. Thank you.
Thanks so much for that, Christina. There are some of you wondering if there were slides. She was just actually speaking through the experience, so it wasn't that there weren't any slides being forwarded. Please continue to introduce yourself and add any questions in the chat. We will be taking time to answer some of the questions after the next series of presentations. I just wanted to provide a very brief overview of South Africa's COVID integration program and set the scene for the presentations that are about to come. Next slide, please. So in January 2022, the Global Vax program's key objectives were to scale up COVID vaccines to vaccinate 70% of the populations globally. In South Africa, we were already asking about how to leverage Global Vax for pandemic preparedness and response. So what happens after COVID? The key priorities were vaccinating priority populations listed here, as well as those at high risk of COVID morbidity and mortality. And so the pivot that took place from scaling up to 70% of the population to prioritizing populations at higher risk of COVID morbidity and mortality was a very critical part of South Africa's program. And now sort of transitioning to routinizing COVID vaccines into primary healthcare. Next slide, please. So integration really starts at the national level with the development and implementation of policies. And in South Africa, we really were partners with the Department of Health from the start of this program. This was done through the support of 4 streams in the National Vaccine Program Management Office that was created, the Health System Strengthening Stream, strengthening data systems, and the creation of and scale up of a National Electronic Vaccination Data System, which you'll learn about more today, supply chain and pharmacovigilance, and then vaccine demand acceleration. It is then important that these national policies and guidance are coordinated with provinces and districts, and to remember that unlike our HIV and TB programs, that this really is a national life course vaccination program. USAID provided technical assistance support to provinces and districts on integration of COVID vaccines into primary healthcare facilities, training of healthcare workers to support integration, supporting the standard operating procedures and screening tools for integration, as well as collaboration with new stakeholders, such as the Department of Basic Education for the school COVID vaccination program. Next slide, please. Reaching priority population is an important goal, but there's a lot of challenges and complexities and figuring out where the priority populations are and what the gaps are to vaccinate them. As you can see on this map in red for South Africa are our PEPFAR supported districts. We leveraged the PEPFAR partners to reach HIV and TB patients, but beyond that, also worked with multiple other stakeholders to reach the elderly, for example, through their social grant collection points, worked with religious leaders to reach people going to churches, and many other platforms to try and make sure that we really were accessing the elderly, people with comorbidities, as well as pregnant and postpartum women. Next slide, please. There was also a lot of targeted outreach in high density areas. And here we really try to leverage Global Vax to provide other health services. And so you can see here, for example, this was in a high density area where in addition to COVID integration, COVID vaccination services, they had somebody from the Department of Health providing diabetes and hypertension screening, HIV services, the provision of male and female condoms, health promotion materials, integrated health messaging. And at that time, we had a measles outbreak in South Africa. So there was a tent providing childhood EPI measles vaccines as well. So really trying to figure out how we can work across different health sectors, not just at facilities, but also when we do these targeted outreach activities to ensure that we are leveraging and trying to provide a multitude of other services. Next slide, please. And finally, we developed a new stakeholder relationships with the Department of Basic Education to reach not only adolescents, but also community members, and especially the elderly in rural parts of South Africa. This was a really interesting way of reaching elderly. We noted that there are significantly more public schools and health facilities. And in rural parts of the country, we found that a majority of elderly in deep rural parts of South Africa were actually getting their vaccines in schools. COVID vaccines are now going to be integrated into the school health program, along with other catch-up vaccines such as HPV as well. So just setting the scene on some of the overall programmatic objectives to reach vulnerable populations and integrate COVID vaccines into routine healthcare services. Next slide, please. So next, Marion Schoenfeld will be providing us with an overview of South Africa's integration process, walking us through the government's, the National Department of Health approach, the country's integration plan, and the partner landscape. Over to Marion. Thanks.
Thank you, Hina, and thank you for the opportunity to present this today. I'm going to take you a little bit back in time and go back to the time when the COVID-19 disease or the pandemic was just declared, and we had to respond within South Africa. So just to set the scene, up to the 1st of February 2023, South Africa had more than 4 million positive cases and 100,000 deaths that had occurred in our pandemic since the onset in March 2020. And you can also see the different waves as the different variants actually spread through the country at different intervals. And you can see the accumulation of cases over time. If we go to the next slide, then you will see how our program started and what our ultimate goal was in the beginning. So we had short-term goals and medium-term goals, of which the short-term goal was to prevent severe COVID-19 disease and death, and vaccinating the vulnerable populations as soon as possible. So initially we started with our high-risk populations, and we worked down to the lower risk populations, with ultimately moving towards our second aim, which was vaccinating 70% of our adult population by vaccinating as many people as possible. So initially with our program, we had supply challenges with vaccine availability, which kind of informed the way that our vaccine strategy or our program rolled out. But ultimately, we provided services within workplace settings and also within the community, largely through outreach services or what we call pop-up sites. We also use other community facilities to provide services such as churches, schools, temporary outreach services, and in the very beginning, we had some mass vaccination sites. And the goal of the overall program was to prevent lockdowns and ensure that we can return to our normal social and economic status, where we can minimize the impact on the economy and all return to our normal processes. If we go to the next slide, it illustrates the different phases that we have had within our immunization program. So in phase 1, we mainly focused on vaccinating healthcare workers. And in South Africa, this was introduced through the use of the Janssen vaccine in a phase 3B clinical trial. And this vaccine was offered within health facilities, focused on healthcare workers specifically. Then in phase 2, we opened up, and in that phase, we started receiving vaccines from our bilateral agreements. So we had vaccines available, and we opened up the vaccination program to people that were older than 60 years of age, and people, and then we phased down in the age groups until we ultimately reached everybody older than 18 years. These vaccines were still mainly administered at a district level, usually administered within a hospital setting, with some outreach services taking place. In phase 3, we had the full rollout where everybody was eligible to receive the vaccine. We also had mass vaccination sites. We had pop-up sites. This was outreach services or targeted outreach services that were provided to specific populations. And there was also more vaccines available. So at that time, there was more than enough vaccines available to go down to the lowest population, and included populations at higher risk and at lower risk. If we move to the next slide, it really highlights the different milestones that we had within our COVID-19 vaccination program. And it starts in September 2020 when a ministerial advisory committee was established for the COVID-19 vaccination program. The purpose of this committee was to advise the Minister of Health on the selection, the procurement practices or the procurement, and the identification of high risk. Initially, the very first advisory that came from this committee was the advisory to participate in the COVAX agreement. So the COVAX agreement was signed in December 2020, and then that assisted with the rollout of the program. So that was different departments. It also included, for instance, our Department of Defense, which assisted with the distribution of the vaccines in the beginning. Then, as I indicated, in February 2021, we started through a bilateral agreement the rollout of the Janssen vaccine in healthcare workers. And on the 17th of May 2021, we started with the rollout of our national immunization program for COVID-19 vaccine. Then if you look at the different months, you can see how we moved from extending it to the 50-year population, then extending it to the people older than 35 years.
Sorry to interrupt you, Marian.
To include adolescents. And we also we had a lot of support from the ADAPT team, and that was available at a provincial level.
Sorry, you're breaking up quite a bit. I don't know if it's possible to move a little. I think your internet is coming in and out, so we're only catching a couple of words every few seconds. Sorry about that.
Okay, that's fine. Let me just try. Hold on. Let me check. Is that better?
Yeah, that is better. Thanks so much, Mary.
Okay, sure. Sorry about that.
So then you can see that in January, we started receiving the ADAPT support. And from there, we established the National Vaccine Program Management Office, as Hina has already indicated. And then we started rolling out to school-based programs. And in May 2023, we opened up the pediatric formulation of the Pfizer vaccine to the 5 to 11-year-olds. So if we look at the data that we have available for vaccine administration since the rollout of the program, you can see that during May, that was mainly our healthcare workers that was vaccinated as part of the agreement that we had with Janssen and the phase 3B clinical trial. And then you can see from the 17th of May, there's a sharp increase in the number of vaccinations, with the highest number of vaccinations taking place between July 2021 and January of 2022. Since July 2022, we have seen a steady decline in vaccinations. We've had some challenges with the expiry date of the Pfizer vaccine being extended at different periods of time, making the vaccine available, or it's in quarantine at some time, but definitely we have seen a steady decline in vaccinations since July 2022. If we move to the next slide, we can see the coverage with the different age groups. And when looking at the coverage of the different age groups, I think it's important to remember that we had a phased approach. So the healthcare workers have been divided in this slide into the different age categories. So they're not kept separately, but it's quite possible that a higher number, even higher than 60% of our healthcare workers were reached in the targeted phase 3B clinical trial that we did in the beginning of our vaccination program. This is then followed by the over 60s at 66% coverage, the over 50s at 65% coverage, and then you can see it declines as we go to the lower age groups. With the overall coverage for the South African population of 49.51%. And then we can move to the next slide, please. So on the next slide, it just highlights some of the achievements and challenges in the next 2 slides that we had with our immunization program. So firstly, we had very high level support and coordination within government and within our technical structures. And I really think that it was a whole of government approach to ensuring that we get the COVID-19 pandemic under control. And it has really contributed significantly to the success of our immunization program. Although we initially had challenges with vaccine availability, with the various models of procurement that we implemented, we were able to mitigate those challenges. So for instance, we had bilateral agreements directly with the vaccine suppliers, but we were also participating in the COVAX agreement. And our participation in the COVAX agreement allowed us to access donated doses, which was very useful in periods of time when we had challenges with our own vaccine availability, especially when the Janssen vaccine was placed in quarantine due to the challenge that they had at the manufacturing plant in the US, for instance. Then because of our targeted approach that we had that was age-based, we were able to target high-risk populations and healthcare workers early in our vaccination program. And that really relieved some of the significant strain that was placed onto our health system. We had a single program that was used in both the private and public sector. So if you are from South Africa, you would know coordination between the private and public sector is at best mostly challenging. And what the COVID-19 program allowed us to do is to have smooth integration and use of the vaccines in both the private and public sector. It established reimbursement practices that will be used in future again. It allowed us to also roll out some of our data systems like the stock visibility system and the EVDS, or the Electronic Vaccination Data System, in both the private and public sector. And it allowed us to then, when we had limited doses of the vaccines available, distribute them as equitably as possible, where people in both the private and public sector had access to these vaccines. Then one of the great things that happened during COVID-19 was the development of the Electronic Vaccination Data System, which Melanie is going to give us more information about. But it really provided us such high quality data, and it informed the entire immunization program to ensure that we could equitably distribute the limited doses that we had, and that we could continue to monitor the coverage in different age groups, which then allowed us to build our demand creation activities specifically to specific target populations. Then we had considerable investment into our vaccination program, of which cold chain is just an example, but we had really improved our cold chain capacity, not only the amount of capacity available, but also the quality of our cold chain capacity that's available, with various trainings that have been offered, the implementation of continuous temperature monitoring devices, strengthening of our distribution of vaccines within the public sector as well. And then we had some improvements in our vaccine safety surveillance system through the introduction of the Med Safety app, which is an electronic application to report adverse events following immunization. And we really did build relationships between our regulatory authority and the various provincial departments of health to strengthen vaccine safety surveillance. We also used a virtual platform known as the Knowledge Hub to train our vaccinators, and we made the facility's ability to actually access these vaccines subject to them having received this training on the Knowledge Hub. And we were able to train more than 60,000 vaccinators within a few months. I mean, it was actually remarkable, and both in the private and public sector. So we had to use these virtual training platforms as well. Then, you know, we had various systems or processes in place to ensure that we had good governance in our immunization program. And that was really informed by our Ministerial Advisory Committee, various circulars, which allowed us to then manage the program through the EVDS program by building in limitations and ensuring that only specified target populations can receive the vaccine at any given time. It also set the foundation for moving forward what our life course vaccination approach would be, and how we will build vaccination programs for adults, whether that is for the influenza vaccine or maybe one day for the HIV vaccine, into our primary healthcare services as part of the comprehensive routine health services that are provided. Some of the challenges that we had and we continue to have is that over time, the demand for these vaccines have declined significantly, influenced by various different factors, including vaccine hesitancy and, you know, social media circulation of false or misinformation. And overall, I mean, we could only reach 50% of our entire population. And at the end of the day, these vaccines have expiry dates. And unfortunately, the vaccines that we won't be able to use would have to be discarded over time. That is my last slide, Hina. Thank you very much.
Thank you so much, Marian. It was great to go back down into history and look at South Africa's over 2 years of vaccine dissemination and all the incredible achievements despite the challenges. Thanks for that. Before we dive into our next session, we're going to launch a quick poll. We're curious to know, has your country integrated vaccination into routine health services? If you can just answer yes or no. And secondly, does your country have an electronic vaccination data management system used as part of the COVID response? Please take a few moments to select yes or no, or I don't know, and submit your response. All responses are collected anonymously. If your country does have experience with an electronic vaccination data management system, please feel free to share more details in the chat, including any successes or challenges. I'll give it a few minutes and then we'll close the poll and just review the responses. Okay, we'll go ahead and end the poll. I think most of you have provided some responses. This is really great. So it's showing that 78% have had some level of integration of vaccinations, COVID vaccinations into routine health services. That's great. But also interesting to note that only 15% of you have indicated that there has been that your country actually has an electronic vaccination data management system. It'll be great to see if there's any lessons that you can take away from the presentation that we will be providing from South Africa. And as well as please feel free to share any of your experiences in the chat, even if it's challenges you've experienced or where your country may be heading next when it comes to integration. Okay. So without any further ado, next, Wendy Ovens will walk us through the integration of vaccination into routine health services in the Eastern Cape. Over to you, Wendy. Thanks.
Thanks very much, Hina. Good afternoon and morning for some. Thank you for the opportunity to present the Eastern Cape integration experience. Next slide, please. The Vaccination Program Management Office, or the VPMO, was established in February-March 2022 to directly support the National Department of Health with the development of national policy, guidelines, SOPs, and strategies to support the implementation and the continuation of the COVID-19 vaccination program. The VPMO is the key link between the national department and the provinces to ensure the translation of policies into implementation. There are 4 core thematic areas, which include health system strengthening, supply chain management and AFI, Electronic Vaccination Data System, or the EVDS, and demand creation. The Eastern Cape was the first province in South Africa to hold a 2-day workshop in which the provincial VPMO structure was established and the implementation requirements were outlined and translated into actions. Next slide, please. The USAID ADAPT program currently provides direct support to 5 provinces in South Africa, of which the Eastern Cape is one. The support includes mobile outreach services, the technical assistance into integration of the COVID-19 vaccine into routine care. The level of effort has shifted over time with a significant reduction in mobile outreach and an increased emphasis on integration. The Eastern Cape, just as by way of background, accounts for approximately 11% of the country's population, with 4.94 million adults eligible for a COVID-19 vaccine. There is a high dependency on social grants, with approximately 40% of the population living in scattered villages with limited access to healthcare services. Integration and the availability of vaccines at facilities are pivotal for ensuring ongoing access and addressing equity. The current percentage of fully vaccinated persons in the Eastern Cape is 45%, with 54% of the population, eligible population, having at least 1 dose. Next slide, please. In South Africa, in 2021, the rollout of the COVID-19 vaccine was a standalone program undertaken through mobile outreach, public facility-based services, and the private sector. With support from USAID EQUIP, prior to the rollout of the general vaccination program, the Eastern Cape commenced its effort by drafting a vaccine strategy in early 2021 to guide the what, when, where, and how. The national rollout, which commenced in May 2021, had strict requirements that primary sites hold vaccines required a Section 22A15 permit to allow the facility to receive and store vaccines overnight, strict cold chain requirements, including a COVID-19 stock visibility system that was separate from a standard SVS. Professional nurses and data capturers were trained and registered on the EVDS with credentials linked to specific individuals. Equipment such as tablets, computers, and data for vaccinators and those assisting the eligible population to register. assigned transport to supply secondary COVID-19 vaccination sites with vaccines, connectivity for real-time EVDS submissions, the establishment of standalone vaccine sites, space dedicated for COVID-19 vaccinations within facilities. And in addition, public sector nurses and data capturers were relieved of their normal duties to participate in both mobile outreach and facility-based vaccine services. In 2021, there were also multiple donors and support partners who were supporting the vaccination efforts here in South Africa. The vertical program was expensive and certainly not sustainable over time, which I'll talk to in slightly more detail. Next slide, please. In early 2022, the Eastern Cape commenced its integration efforts to take advantage of the support from the National VPMO and, more importantly, to ensure ongoing access to a COVID-19 vaccine as the mobile outreach efforts declined and staff returned to their new normal duties. In April 2022, a COVID-19 scale-up planning workshop was held in the Eastern Cape in collaboration with the National VPMO. The workshop outcome was drafted into a provincial high-level strategy in which integrating the COVID-19 vaccine into routine healthcare services was pivotal. Through the Eastern Cape VPMO, the province also developed a high-level SOP to guide the vaccine integration into routine healthcare services. USAID appointed and trained integration roving teams to provide technical assistance. Facility-based engagements commenced in July 2022. In collaboration with the Department of Health, facilities were prioritized for onboarding, direct support, and maintenance. Additional facilities were included per quarter, with ADAPT now supporting 244 facilities in the Eastern Cape, 28% of all public healthcare facilities in the province. The ADAPT teams also undertook district-wide training on integration, EVDS, and demand creation. The training included both ADAPT and non-adapted supported facilities. Next slide, please. Moving from a vertical program to integration certainly has its challenges, compounded by the requirements attached to the COVID-19 vaccine in the South African context. In most instances, staff returned to their normal duties, standalone vaccination sites were dismantled, COVID mobile outreach reverted to primary healthcare services again, and then vaccines were not included in that package. Once the national mask wearing mandate was removed, there was a general perception that COVID was over. This is the environment in which the ADAPT teams were required to commence the onboarding and technical assistance. Conditions varied from facility to facility, with some showing significant resistance to others embracing the support. Next slide, please. ADAPT has established 4 roving teams to provide direct technical assistance to priority facilities in 7 of the districts within the province. Each team includes an HSA specialist, a pharmacist, M&E and EVDS officer, and a demand creation officer. The composition matches the 4 VPMO work streams as well. The workflow included an introductory meeting at the facility, completing a facility readiness assessment linked to a quality improvement plan, and repeat visits to address the gaps. From the outset, the Eastern Cape ADAPT team set up monitoring tools to track performance. Importantly, the teams have also worked with other partners, such as the WHO provincial representatives, who were working on the impact of the COVID-19 pandemic on service delivery at the primary healthcare level. The pharmacy team also supported the distribution operationalization of the cold chain equipment donated by KFW. Next slide, please. While each team member has a specific focus area, teamwork is essential for addressing the interrelationships between the streams. The team's responsibilities cover all aspects of the COVID-19 value chain and require engagement with a wide range of facility staff, from the operations manager, professional nurses, data capturers, admin support, pharmacists, and community healthcare workers. Each plays an important role. A break in any part of the chain will contribute to no or underperformance at the facility level. For example, if the operation manager supports the need for integration, but the professional nurses do not offer provided initiated vaccines, vaccination numbers will be low or will not occur. It's about building a facility-based team. Next slide, please. The challenges found by the roving teams at the facility level were across the COVID-19 vaccination value chain. Some are quick and easy to address, such as expired EVDS credentials, knowledge limitations, the incorrect use of cold chain equipment, and ensuring the availability of demand creation materials. Others are beyond the team's control, and indeed that's of the facility, such as no connectivity, limited space, commonly found in pharmacy sections, load shedding, etc. Many challenges are staff related and reflect poor teamwork within the facility and generalized resistance to what's perceived to be additional tasks. After 6 months of engagement with facilities, it was evident that ADAPT needed to introduce a change management strategy. With the support of USAID, the Eastern Cape team was trained in the MSH Leadership Development Program Challenge model, which has been rolled out in facilities. The team has identified poorly performing facilities and targeted those. The results are certainly encouraging. Next slide, please. The ADAPT experience has also demonstrated that when one challenge is resolved, others emerge, what we have referred to as the challenge cascade. A good example is the provision of a vaccine fridge, but then an unreliable supply of electricity, no backup generator, limited access to diesel supplies, etc. Successful integration requires a targeted, comprehensive approach with the ability to address the intended and unintended consequences of the intervention. Next slide, please. The ADAPT team learned early on that the integration process that we needed to streamline the tools for collecting and managing data. The Eastern Cape COVID-19 response team has a strong practice of using data for decision making, and that goes back to the early days of the pandemic. The real-time integration dashboard allowed the program to quickly identify common areas requiring intervention beyond the facility. For example, transporting vaccines between facilities, a common problem in the Eastern Cape, cannot be addressed by the facility, but rather at the sub-district, and in some instances required district interventions. The team has also monitored the facility data post the change management intervention, with the results fed back to the facility to provide support and encouragement. Monitoring the national and provincial data on the Health Information Center Integration Dashboard has recently informed the need for a further pivot, which I will discuss in a moment. Next slide, please. The Health Information Center data demonstrate an increased reliance on public facilities for access to a COVID-19 vaccine. In the Eastern Cape, outreach services have declined from 39% of all sites in 2021 to only 21% in 2023. 88% of the primary vaccine sites are now in the public sector. In the Eastern Cape, ensuring that the effective integration of the COVID-19 vaccine into routine care in fixed facilities and primary healthcare mobile outreach services is critical. Importantly, the COVID-19 vaccine provides an opportunity to build a sustainable platform for the introduction and the management of an adult vaccine program. Next slide, please. The data shows that the ADAPT-supported facility largely perform consistently. As mentioned earlier in the presentation, only 28% of the facilities receive this support. Those facilities without ADAPT support are falling behind, and in many instances, vaccination efforts are collapsing. The program needs to refocus with increased support at the provincial and district levels to directly impact all districts and sub-districts, and obviously then facilities within the province. We have certainly found the need to ensure the balance of the level of effort at both the top and bottom to manage the interrelationship between the two. Next slide, please. The lessons learned in the Eastern Cape supported the scale-up of the National ADAPT program. The structure and the roles and responsibilities of the roving team members have been rolled out in other provinces. All ADAPT teams now use the integrated Survey 123 facility readiness assessment tool. Again, with USAID support, the KwaZulu-Natal teams have also been trained and have commenced the implementation of the challenge model. The use of data is now an active part of the National VPMO HSS activities, guiding the support required by the different provinces. Next slide, please. Just thank you very much for this opportunity. Over to you, Hina.
Thank you so much, Wendy, for a deeper dive to see how some of the national level COVID vaccine policies and guidance are then actually implemented at the provincial and facility level, and some of the incredible achievements as well as challenges in trying to do this. We're just going to pause here. We have about 8 minutes before the next session to give the opportunity for questions and answers. I'll read out a couple that are in the chat. The first one is, how did you overcome anti-vax sentiments in patients and in medical staff? Marian, I think this was based on your presentation outlining some of the challenges around vaccine hesitancy. So want to know if you'd like to take that. Thanks.
Sure, thank you. So with our VPMO and ADAPT support, and even before the ADAPT support, we did establish social listening. I think that is a very useful tool that we implemented to identify exactly what is happening within our communities, what are the leading causes, what are they talking about, you know, especially when there was reports or false reports, misinformation about adverse events that could be addressed immediately where possible. And then obviously training. The more you talk to your community, the more you talk to the healthcare workers about the information that they're required to encourage vaccination, the better information they have when they are confronted with misinformation. Thanks.
Thank you so much for that. There was also a comment in French by Ulrich that I'll read out, and it was around their experience with their immunization program, where he says, our immunization system has a special routine immunization program with our partner Gavi and other projects. We believe that the immunization chain is decentralized, but in community settings, immunization is an activity in which only the population sets to work to achieve immunization coverage with little or no financial incentive in some remote and inaccessible areas, simply because the public authorities have their hands on the incentive envelopes of the relays. So only the volunteers in the health facilities actually end up providing immunization. And this does not reach the populations in remote areas. My suggestion would be to set up a parallel community system managed by communities themselves, which would give better results. In the Congo, only the main towns in the major cities make vaccinations available, and people in the outlying areas hardly ever receive doses on a regular basis. I don't know, Wendy, if you'd like to just comment on how South Africa has dealt with the issue of equitable vaccine coverage. I know that it's a very heterogeneous population. There's no one size fits all. And what have been some of the experiences in trying
experience. And I think what we have done in the Eastern Cape to make sure that we were reaching the hard to reach, especially in the deep rural areas, is that we used a system where we had a scout go out and work with all the community leaders, traditional leaders, church leaders, and make sure that the community were well informed before we actually went into the area to vaccinate. We found the other thing that we did is, and I think you mentioned this in your presentation, is because there are more school facilities, especially in these remote villages, we use those schools as the way to not only vaccinate the learners, but more importantly to vaccinate the surrounding communities. And what we did find by doing that, we were able to target in the deep rural areas, reaching the elderly. And I think the results that we've had in terms of vaccinating populations over the age of 50 has been very successful. The one thing that we have done, and it is specific to the Eastern Cape, is that we have not used any incentives to encourage people to vaccinate. And we did that on purpose because we found that if you offer offer an incentive once, that information spreads through communities like wildfire, and then you have to keep on doing that. So we opted never to use an incentive to encourage people to vaccinate and or to have a health-seeking behavior, to promote health-seeking behavior. So I'm not sure if I've answered your question adequately. Thank you very much.
Thanks. No, that's really helpful, Wendy. There's a couple more questions here. I'm going to read both of them out, and I think, Marion, you would be well placed to respond to them. The first was, has the government, as part of integration efforts, initiated budgeting for COVID integration into routine planning and budgeting cycles? And what will be the prospect for VPMOs at the national and subnational levels? And then I'll read out the second one in French as well. Is it true that the Johnson & Johnson vaccine is no longer being manufactured? And if so, why this vaccine was more convenient for integration? Over to you, Marion.
Thank you. So let me start with the second question first. Yes, the Janssen vaccine is no longer being manufactured. It's a vaccine that we rolled out within the South African context because initially there's only a single dose required for the completion of your immunization schedule, which was very attractive to most countries. Also, the distribution of the vaccine was better in terms of context, that you could store it at -20 and you can store it for an extended period at 2 to 8 degrees Celsius. Also, the packaging, it was available in 10 vials as a minimum order quantity, which is also really useful within an immunization program. But the vaccine is no longer being manufactured, and it's probably because of the global decline in demand for these vaccines as well, and companies are reprioritizing their vaccine production to vaccines that are used more generally. In terms of integration, in terms of resource allocation, yes, within South Africa, there will no longer be a centralized funding for the vaccines for the COVID-19 program, but it will be integrated within the provincial allocations for the provision of other health services. We are planning to continue our immunization program for high-risk populations, although it will be totally integrated from resource allocation to service delivery. Thanks.
Thank you so much for that, Marion. I'm going to pause on the remaining questions and get to them after our next presentation as we run out of time. So next, Milani Wolmerans will be providing a deep dive into the scale-up and implementation of South Africa's Electronic Vaccination Data System. Over to you, Milani. Thank you.
Thank you very much for the opportunity to share this initiative from the South African government. It's a privilege to share with you our Electronic Vaccination Data System. Next slide, please. So I'm starting off with the policy context because, like Marion has mentioned, one of the big complex issues in the South African health system is creating collaboration between the public and the private sector. So there was a policy decision that the electronic vaccination data system will be, or has been adopted as the only and the official system for capturing COVID-19 vaccination events by everybody that administers COVID-19 vaccinations. It's the first time in the South African history that an information system that was developed by government, owned by government, resourced by government, has been embraced and adopted for implementation by both the public and the private sector, which we see as a major achievement and also set the tone for quite a number of key collaborations. Next slide, please. So when we talk about the electronic vaccination data system, we talk about the electronic vaccination data system ecosystem. It consisted out of 4 main components, and each one of these components and solutions together formed the EVDS. The first one was with regards to population enrollment and the scheduling, indicating to individuals where they can go for a vaccine. In the beginning of the vaccination program, when the vaccines were limited vaccines, also making sure that the vaccines, like Marion has said, distributed equally, and therefore a scheduling or appointment system was included. The enrollment system allowed for self-enrollment on an application, a web application, or assisted enrollment at the vaccination site. Then South Africa has got a platform called the Master Health Facility List. Utilizing this platform allowed us to create functionalities for the registration of vaccination sites, allow for the selection of sites, the activation of sites, also looking at how do we approve and curate sites so that they comply with the minimum requirements to administer the COVID-19 vaccine. And then every vaccination site needed a permit as part of our legislation to be able to administer a COVID-19 vaccine. Then the actual capturing of the vaccination events, which first of all started with the verification of the demographic details of the person as per the enrollment. Then there was a basic health questionnaire that was administered. There was consent administered, and then the vaccine was captured, including the details of the vaccine, the manufacturing, the batch date, and the person then received a date for the next vaccine, if it's a 2-dose vaccine, or if it's a booster vaccine, when they need to come back for the booster vaccine. This EVDS ecosystem collectively then, oh sorry, I left out the important one, was the data and information platform. So South Africa Department of Health owns a big data platform in the form of a data lake. This then allowed us to provide, in the beginning of the vaccination program, real-time data, where the vaccination dashboard updated every 2 hours. As the vaccinations increased per day, we had to then just tone down on the updating of the dashboard, and it was then updated daily. It also allowed us to be able to inform the public on a daily basis with regards to details of the COVID-19 vaccination rollout, where we had a public dashboard which was published on the SA Coronavirus website, and where anybody that had access to the internet could access information. The information collected and the data collected through the EVDS, and including the different components of the EVDS ecosystem, then also informed the stock visibility of the vaccines in terms of determining the demand, where the vaccination sites were, doing reconciliation on the use, the lost, and the wastage, and supported the data analytics with regards to vaccine stock. Next slide, please. So the EVDS was designed in a very complex COVID vaccination program, where a number of changes continuously were happening. There was a number of key processes that wasn't 100% clear and defined, like at a stage, the period between the 2 doses of Pfizer were 42 days, and then as vaccines became available, it had to be changed to 21 days. The number of the controls had to be changed. So the EVDS was designed in such a way that it could respond to the needs of the vaccination program. And like indicated, it was the authoritative registry to track the various vaccination program metrics. It allowed for accountability, huge expenditure on the purchasing of the vaccines was incurred by the country, and therefore it could provide information with regards to where and how the vaccines have been administered, information on vaccine wastage, and also looking at forecasting of vaccinations, which then is streamlined with the budget allocation and management. The fundamental purpose of the EVDS was also to connect those who are seeking a vaccine to a registered vaccination site. And there was quite a number of additional functionalities and applications developed in order to be able to inform the population around where vaccination sites are. Also, a solution supported or linked to the EVDS was developed where you could schedule your own time and date and vaccination site where you would like to receive your vaccine. What is important was that, and this is one of the success stories of the EVDS, was that we had uniform processes and workflows across all the stakeholders, and that then allowed for equitable access. But it also allowed us to have an electronic vaccination data system that was uniformly deployed and then utilized at all vaccination sites. Like Marion has shown, I will also show you a few dashboards. It gave us up-to-date vaccination coverage across all the age groups, subpopulations, which then showed the optimal return on investment. And then also it was designed to ensure compliance with the regulatory requirements from the South African Health Product Regulatory Authorities and enforce best practices during the vaccine administration. Next slide, please. We had to apply very stringent data protection and governance policies to comply with all the legislative requirements, and also ensure that the use and the processing of the data was managed in a responsible and ethical way and aligned with the in South Africa. As of today, there has been no transgression with regards to the protection of the personal information or the electronic vaccination record of the person that has been vaccinated. It also gives information with some research projects to look at the effectiveness, the safety, and the durability of the vaccines. And quite a number of research papers around this has been published by different research institutions in South Africa. It also reduced the need for paper-based records, which often is lost or it ends up in boxes, and the information is not available for the management to take management decisions and also for accountability. There was a strict reimbursement model that was implemented, and where the medical aids needed to refund the National Department of Health, and the EVDS solution, especially as it relates to the enrollment component, could be used to verify medical aid data and to collect medical aid data. The EVDS provide the vaccinee information for the no-fault compensation process, and it is the design approach of the EVDS is will allow for adaptation to support for future vaccination and other public health prevention strategies. Next slide. So I'm not going to go into detail, but just to indicate that this was the basic workflow processes. But then just to look at the green box is that the Electronic Vaccination Data System then provided the information for the Electronic Vaccination Certificate, which was then also seen as the vaccine passport, and that was required especially for travel outside the country, but also as more institutions open up for economic activities, there was requirements for vaccination certificates where each individual could download their electronic vaccination certificate. Next slide, please. So if we just look at the development snapshot of the Electronic Vaccination Data System, so one of the key considerations that we needed to take into account was that we needed to deploy a system that is intuitive. So it needed to be easy to use, and it needed to cater for all levels of digital literacy within the health sector and the public environment. And therefore, it was designed in such a way that it continuously gives cues in order to be able to assist the use, the efficient and effective use of the EVDS. We deployed the integrated system so that not only use a web-based solution where you needed internet access or an internet browser to enroll. We also use USSD and WhatsApp for enrollment, so that we had the broader population that could enroll for the vaccination. In terms of the rapid deployment context, and I will explain the timelines just now, we focused on simplicity. We have done quite a lot of work for the development of the National Health Insurance Data System. And we could leverage on that, that work that has been done for the development work that has been done for the National Health Insurance Data System. It was a cost-effective solution. And the main thing was, and requirement was, that data needed to be available in near real time in order to support the vaccination program in South Africa. We used, I often say that we used an agile on steroids approach, but it was an exceptionally agile approach where there was daily interactions with the different development teams, the business owners, business analysts of the EVDS, in order to be able to stay aligned with the vaccination program and the decisions that has been taken by the vaccination program. And then it's a national web-based system that's online, which has been zero rated by the South African government. So therefore, minimal data is required in order to be able to use the EVDS. Next slide, please. If we look at the deployment of the National Electronic Vaccination Data System, so on the 2nd of January 2021, I was phoned by the Director General of Health, the Head of Health in South Africa, with the instruction to develop a vaccination data system for South Africa. in 2 weeks, we looked at the requirements, the scopes of the Electronic Vaccination Data System, trying to at that stage, the vaccination program in South Africa was still in its planning phase, and working out detailed key processes and controls. From where the scope and requirements were signed off, we went live with the EVDS within 4 weeks. The deployment started, so on the 7th of February, 7th and 8th of February, using the Knowledge Hub, which is also a USAID supported training platform. We virtually trained 7,500 vaccinators in 2 days, and started with the creation of the vaccinator accounts, which was decentralized to different organizations in the private sector as well as at the provinces. And we saw the first phase of the vaccination program until when the healthcare workers were vaccinated as our beta testing phase. And that was from the 17th of February to the 31st of April. And then on the 17th of May, like previously indicated, the vaccination program was then the full South African government vaccination program was implemented and taken to scale. So at this stage, that's where we got support from Right to Care through the USAID funding to assist the National Department of Health with this rollout to scale. And were actually assisting us in developing training modules, change management, project managers, data analysts, epidemiologists, etc. A lot of technical support. And I just need to acknowledge that if it wasn't for that technical support, I am not sure that we would have been able to roll out at the pace that we have rolled out during that time. So now we're at the stage of integration into routine services. Currently, 42% of primary healthcare services, primary healthcare facilities are using the EVDS as part of the routine health services in South Africa. It's just over 1,200 primary healthcare facilities. This scale up and integration into routine health services and the use of EVDS in our public health facilities as part of the integration program is also then supported by Right to Care through the USAID funding. So a lot of people don't believe us, but in terms of, we have an excellent development team that is from the Council for Scientific and Industrial Research, a government entity, and they continue to support the EVDS solution. Next slide. So if we just talk about the data, and I'm just going to, this is just a screenshot of the data, one of the data products around the COVID-19 vaccination. So if we look at week 42, which was the peak of the vaccination program, then we had 4,029 vaccination sites that were registering and capturing a vaccination on the electronic health record of the persons that got vaccinated, which was quite significant if we look at that. The next slide, please. So this is just demonstrative of another key dashboard where the detail is available around the vaccines that has been administered. As of yesterday, as of Monday, we're now updating the dashboard on a weekly basis, given the decline in the number of vaccinations. So as of Monday, 39,082,000 individuals or vaccines has been administered. And then this gives us the details of the different vaccines. So in terms of 22,800,639 individuals has received at least one dose, then the second dose, the booster doses, the immunocompromised additional doses, the general booster doses, and the continuation of booster doses. And then it also will give information with regards to the different provinces, and then in both the public sector and in the private sector. But it's also possible to tailor-make this dashboard to your need, where it's possible to drill down up to facility level. This is just the Eastern Cape. Then we've got the district, and this is the hierarchy of health services in South Africa. So we have the province, which is Eastern Cape, and then we have a district, health district, and then we have health sub-districts, and then an indication of the vaccines that has been administered. And then you can further drill down into each facility. It's also possible to select the vaccine type, can select a specific age group, we can select the sex, and we can also look at very specific vaccination weeks, and it's also possible to select a specific time frame. On the left-hand side, on the right-hand side, there's the indication of the different dashboards that's available just around the vaccination program, and the details around the vaccination program that's available on the National Health Information Center. Next slide, please. So one of the key things that to look at is the issue of reaching vulnerable populations. And one of the areas that I mentioned to say that there's a health questionnaire that has to be administered before the vaccine is being administered, where a person is then being asked if they've got any of the chronic diseases, which is regarded as making you vulnerable for COVID-19. And this is just giving a snapshot of the dashboard that we have available. This is a reported information, so the individual is reporting, for an example, that they have got diabetes, or that they have been diagnosed with TB, or have hypertension, or is HIV positive. So if we look at, for an example, those that are HIV positive, that might be immunocompromised, then a total of 3.3 million individuals has received the COVID-19 vaccination. Again, on the right-hand side, gives some details in the level of detail that you can go into with regards to further drill down and get further details around this information. Next slide, please. So with regards to the concluding remarks, for us as South Africa, we have demonstrated that a national digital system is not only possible, but it is essential to responding to public health issues. So during the COVID-19 era, we scrambled around because information and data around individuals were in silo systems, disparate systems, and not integrated into one solution, where it was possible then to use the data information to prepare a response for COVID-19, but also around the COVID vaccination program. So South Africa has decided to start the development of a fully fledged electronic medical record. This is also in preparation for the implementation of national health insurance, which is the strategy for South Africa to implement universal health coverage. So we are in the process of developing the first module of the integrated electronic medical record for South Africa, focusing on HIV and TB. This then will allow us to start merging quite a number of solutions that has got personal identifiers. And one of them is then the Electronic Vaccination Data System. So linked to the platform that I have just show you some screenshot is then also as part of our data analytics and our data lake functionality is a geospatial platform where it would be possible then to start identifying where are some targeted areas where the focus should be on vaccinating more of this the vulnerable population that could be immunocompromised. So what we are, so it has started, we are in the development phase. We should be starting implementation towards April 2024. We also, during this process of the electronic vaccination data system, different communities of practice have been established, and which has led to quite a number of co-creation and contribution into streamlining the electronic vaccination data system in order to be able to respond to the COVID-19. And there is many lessons to learn, which we are still planning to record in terms of the lessons that we've learned in the development, the rollout, in terms of the use of the EVDS, which could contribute to the preparedness for future pandemics. But one of the key things that we have discovered during COVID-19 is the need for an electronic medical record, which would allow us to be much more responsive to pandemics, but also will support disease surveillance. The implementation partnership with Right to Care that we had since May 2021 is demonstrative and it's a success story of implementing a fully government-led program, and it was supported by donor funding. But the ownership and the governance and the accountability remained within government and within the EVDS program office at the National Department of Health. In establishing this partnership has demonstrated how it's possible for us to work together with one focus and one goal and one aim to reach a common outcome. And it's definitely something that can be built on, and also establishing more of these partnerships. The digital data intelligence has proven to be most effective strategy towards the prioritization of the vaccination activities. And then, like I've mentioned, the electronic vaccination system has catalyzed South Africa's capabilities to digitally support the universal health coverage agenda. We definitely will continue to build on what we have developed and managed to roll out during the COVID-19 vaccination program as we are moving forward in our trajectory to develop a uniform, integrated digital health solution for South Africa. Thank you very much.
Thank you so much, Milani. Really appreciate that very detailed overview of the EVDS system. Thanks everyone for the wonderful questions you posed. We've unfortunately run out of time. We will try and get responses to all the questions and send you the slides as well as the responses to questions going forward. Once again, a real gratitude to all the speakers for taking the time to provide this incredible overview today on South Africa's COVID vaccine scale-up and integration program. I think some incredible learning experiences for other parts of the world as well, and some best practices. I will hand this over now to Anne, and thank you again very much for everyone attending the webinar today as well. We have one last poll and some closing remarks. Thanks.
Well, first of all, thank you to all of our speakers and our moderator from USAID, the National Department of Health, and also the Right to Care Project. Thank you for the great presentations. If you have any questions for any of the speakers today, please feel free to reach out to me and I can put you in touch with the correct person. Before we wrap up today, we'll be sharing a link in the chat to the Knowledge Success website where you can find additional resources related to COVID-19 vaccination. I encourage you to check them out. As we mentioned earlier, this is the second in a series of 3 webinars focusing on COVID-19 integration. So with that, we wanted to launch one final poll to ask you all what topic would be of most interest for the 3rd and final webinar, which will happen in September. So please feel free to respond to this poll. And thank you again to all of our speakers and to our presenters and our moderator and to all of you for joining this session today. So once you've completed the poll, feel free to leave the webinar and we will be sharing a recording and the slides and responses to any of the questions we weren't able to get to in the chat via email shortly. So thank you everyone and have a wonderful day.